All right, hello, and thank you for joining us for today's webinar, Keeping Pediatric Patients Safe with Virtual Sitting, brought to you by Avishere. AONL is pleased to host the Industry Insights webinar series as an opportunity to connect AONL members and partners who share their knowledge, research, and application of solutions to industry challenges. Feel free to ask questions at any point during the presentation by submitting them through the Q&A feature. The presenters will address them at the end of the presentation. Now I'd like to introduce our facilitator for today's session, Dana Pico. Dana is the Director of Clinical Sales at Avishere. She will introduce the rest of the panelists. At this time, I will hand it off to Dana to get us started.
Thank you so much, Megan, and thank you everybody for joining us this afternoon. We are so excited to go ahead and start to talk with you about keeping our pediatric patients safe. What we want to do is first cover our learning objectives. So as you see here, we're going to cover a plethora of information for you, especially about our pediatric patients. We have two esteemed colleagues that are joining us, but some of your learning objectives are your policies and procedures that are needed for video monitoring in your pediatric environment, how to get buy-in from your frontline team to use technology for this sensitive patient cohort, and why virtual sitting is a solution to address the top patient concerns for 2023. With that, we're going to go ahead and I would love to introduce our panelists. So we have two fantastic nurses on the call today. So I will start with Catherine. Catherine Mitchell is an experienced ICU nurse with over 16 years of experience in providing critical care to patients. For the past 9 years, she has been the house supervisor at Baptist Jacksonville, ensuring high quality patient care. In 2021, Catherine took on the role of nurse manager of the centralized monitoring unit and video monitoring units. Leading a dedicated team, she has effectively overseen the centralized monitoring of patients through a network of 120 cameras across 9 different facilities within the health system. Catherine's expertise in utilizing technology and her commitment to patients' well-being has made her an invaluable asset to the healthcare community. And on a side note, just so everybody's aware, Baptist Health has monitored over 1,247 pediatric patients during their program. If we were in a big group, I would say let's applaud for Catherine. Next, I want to highlight Melanie Lee. Melanie Lee is a clinical director of nursing for the Pediatric Emergency and Inpatient Unit at Luminous Health, Anne Arundel Medical Center in Annapolis, Maryland. She has over 20 years of experience in pediatric nursing and is certified in pediatric nursing. In 2021, Melanie was nominated for the Washington Post Star Nurse Award for her work in improving the experience of pediatric mental health patients in the emergency department. She has implemented several initiatives to make the ED more child-friendly, ensuring that kids get in and out of the emergency department as quickly as possible while still receiving the highest level of care and compassion. As a side note, according to our online reporting nursing analytics tool, Anne Arundel has observed 2,444 pediatric patients. So yay to both presenters. I really appreciate your time today. Before we dive into your program, I think it's fair to go ahead and level set what Avishere is and who we are so that you can kind of put your mind around the technology that is being used in both of these facilities. Avishere was the first and we were the ones that invented the telesitter solution back in 2008. We have over 1,000 hospitals using our technology today. One of the prideful moments of Avishere, I think, and what motivated me to come and work at Avishere as a nurse is the amount of nurses that we have on our staff here. We have close to 20% of our population of employees are registered nurses. My background particularly is neonatal nursing, so this pediatric webinar is near and dear to my heart. I think it's an invaluable resource for our bedside nurses to have some support at the bedside, especially from a virtual perspective. When we talk about what Avishere can offer, if we go to the next slide, you can see we have virtual care models that we are deploying across the country. What we're really going to focus on today is a telesitter model, and what this does is it really helps you to decrease those one-on-one bedside sitters and use a telesitter in its place. And I know many of you are probably joining this thinking that AvaSure is just for fall risks. And we know that the patient population is completely different in a pediatric environment than it is in the adult acute care. We know falls are not as the highest priority as other events that happen in a pediatric hospital. So I think this is going to be a really fruitful time for you to hear some of the use cases, the patient population, the inclusion and exclusion criterias that both Melanie and Catherine are using in their organizations. But with that, we do also offer some virtual nursing capabilities as well. We have the clinical resource telenurse, and what that's really geared toward is really augmenting your staff, especially in this time of crisis when we don't have enough bedside caregivers or nurses to really help and facilitate a lot of the tasks that need to be done, such as admission and discharge, patient family teaching, and then even specialist consults. What we're seeing a lot is wound and ostomy care nurses really lending some support virtually to our bedside caregivers. And then the other model that we really like to, what I would like to highlight is our expert oversight telenurse. In the pediatric environment, one of the use cases that came to light at the beginning of the year was the crisis that we were having with RSV and COVID running rampant in our hospitals. And obviously those patients are in isolation. So this was a wonderful tool to use to be able to have visualization of those patients. It's a 1:38 model. So you can monitor up to 38 patients at one time. And the way that I like to think about it is in a command center environment. So you could have your cohort of patients being monitored visually through the Avishere technology. You can have your physiological monitors up and running, and then obviously you're going to be working through your EMR. But just think about those patients back when we were having that crisis, those RSV patients, and being able to keep an eye on those patients with the door closed. If mom and dad are in the room and you quickly see mom and dad jump up and rush to their child, it gave you an understanding and it allowed you to go ahead and speak to those parents directly and quickly to see what their needs are so you can get the appropriate caregivers to the bedside. With that, we've talked a lot about Avishere, so now I think it's time to talk about the telesitter programs that we have both at Anne Arundel and then at Baptist Health. So I'm going to start with Melanie. And the reason why I'm starting with Melanie, I think her use case is really unique because she started to deploy this in the emergency department. So Melanie, why don't you go ahead and tell us about your deployment of Avishere there at Anne Arundel?
Sure. Good afternoon. Thanks for having me. So our journey with Avishere started about 3 years ago. We are located in Annapolis, Maryland. We're a community hospital. We see about 22,000 pediatric patients come through our ED a year. And about 10% of that volume is for pediatric mental health. And that is just kind of continuing to increase, unfortunately. So the majority of our usage is for those moderate risk suicidal patients, removing the actual in-person sitter at the bedside and moving forward with the telesitter monitoring. My unit is considered a hybrid unit, so it's a little unique in that it's an ED and an inpatient unit all in one. Staff works both sides. We don't utilize Avishere as much as on inpatient, but we have, particularly for anorexia patients that needed to be monitored with their food intake and getting on the scale. So we have used that in that setting, but the majority of our usage is in the pediatric emergency department.
So can you talk a little bit about, and then we'll move over to Catherine, what type of devices are you using? Because I know one of the big challenges and concern is obviously in an environment that you're monitoring for suicide ideation, especially in our pediatric population. What kind of devices are you using so that way people can kind of visualize how you're doing that?
So we have the rolling monitor. So it looks a little bit kind of like a disco ball, I guess I could explain it, on a tall, skinny, mobile. It's lightweight, it moves flowingly. It's really nice that they're mobile because in an ED, it's not uncommon that we have to realign patients and move them from one room to another just based on our acuity. So it's nice in that sense where you can roll the monitor with the patient. Trying to think, did I answer your question? Sorry.
Yeah. Well, and it leads me to another one, which I know somebody's probably thinking about right now is, well, you obviously have a plug with that and you have to plug it in. What is your concern about ligature? I know a lot of organizations prefer a ligature-free environment. So can you talk through how you work through that?
Yeah, so we are not a pediatric mental health unit. And that, we're very clear on that. What we do try to do is remove all the ligature risk as much as possible from a room, but knowing that we are not a pediatric mental health unit. The plug for the Avisure is not very long. And the way that our rooms are set up, it goes nicely kind of behind, like up to the back of the wall where it can remote, plug in right there. We've never had any issues in our 3 years of using Avisure with any patient trying to use the cord as means to harm themselves. That has thankfully never been an issue for us.
Perfect.
Yeah, and I think the face behind the camera is so alert and in tune to things that are happening. As soon as the patient gets up, gets close to the doorway, gets near anything that could be a potential risk, they hit the alarm and staff responds immediately.
Great. Thank you so much. So Catherine, tell us about how you are using Avisure and what type of patient population you're using with your pediatric patients.
Sure. Good afternoon. Thank you for having me, Dana and Avishere. So we have some similarities to what Melanie discussed. We use our Avisure mobile cameras at any of our EDs, including we have 3 freestanding EDs within our health system that we have cameras currently located in, and they can use those devices for the pediatric population there. In addition to the use in ED, we have Wolfson Children's Hospital that is part of our health system, and that is a pediatric hospital. And they use the cameras both in a ED behavioral health pod. And in that ED behavioral health pod, which is a holding area for patients that are admitted to inpatient but have not gotten into an inpatient room yet, we have 8 ceiling tile cameras. And that is where we use those 8 ceiling tile cameras is within the ED pod. So they are cameras that are literally located in the ceiling. The dome comes through the ceiling. And those cameras enjoy the same benefits that the mobile cameras do with 360-degree pan tilt zoom. They're able to move around the room with the patient. The tech is able to move them around within the dome. And we use those ceiling tile cameras in that population to alleviate any physical concerns we have with the cameras. So we don't want the children clearly to harm themselves with the mobile devices, or it would be really hard for a child to do that, by the way. They're very substantial bases that, like Melanie mentioned, roll really well and really easily, but they are large and heavy enough that you cannot pull it down upon yourself. But those ceiling tile cameras are put into place, and we're actually growing our Avisure program within the pediatric population to include a behavioral health inpatient unit with ceiling tile devices so that the children are not able, it's an additional measure to ensure the children are not able to hurt themselves with those cameras. So we watch, similar to Melanie, we watch patients for the same issues. Our hospital policy allows Avisure to be used for low to moderate risk, Baker Acts, for suicidal or homicidal ideation as determined by the mental health evaluator or psychiatrist. But we use our cameras a lot for eating disorder patients. We have a substantial autistic population that we use the cameras for. Again, falls, that's not as common as the adult population, but medical device interference, we use it a lot with children who have PEG tubes or have trachs, or we're concerned about them pulling out their IV or PICC line. And then we have used them in situations where we're concerned about parental or sibling abuse. We will use the cameras to watch family members or any visitors inside the room to make sure that the children are safe. And then any combative patients, we commonly use our cameras to make sure that they are not combative towards other staff members or themselves, self-harm situations. So we have a mixture of both mobile and ceiling tile cameras, and we enjoy the benefits of Avisure through both types of cameras.
Perfect. We are going to run to a poll in just a moment, but before we do, for both of you, there was a question in the chat. How many patients to virtual monitor tech do you watch in a pediatric environment? So Melanie, I'll start with you. What's your ratio of observer to patients?
So we share our monitoring system with our systemness of our hospital and kind of our sister hospital, but the max that would ever be watched at one time is 14. We have the highest usage rates throughout the hospital, and there's generally not 14 on the camera at once. I think the average is around 9.
Okay. And what about you, Catherine?
So for our adult inpatient and an adult population, we have a ratio of 12 to 14. For the pediatric population, we have a ratio of 8 to 10. So no tech, safety monitor tech is what we call our techs that are watching the patient. They do not watch more than 10 pediatric patients at a time. It's usually around 8.
Okay, perfect. So with that, before we kind of dig into a little bit more of what, let's do our first poll of the session. And it is to our guests, all of our people that are joining us. Are you using a virtual sitting platform today is our question. And I will venture to say that many of you are probably not. That's why you're joining us. But it would be nice to know if we do have anybody on the line that is actually using something today. And we're getting them in quickly. Oh, yep, see, not many. We will give that a couple minutes. All right, so about 66% of you are saying no and 34% are saying yes. With that, thinking about your population of your patients and your programs, what comes to mind to me as a nurse, as a NICU nurse, how in the world did you get your staff to buy in? And I think about my many, many years of experience. Us pediatric nurses or neonatal nurses are super protective of our patients. We sometimes think of them as our own kiddos, right? We want to protect them. And sometimes we have the mindset that we're the only ones that can do it and do it successfully. So I'll start with you, Catherine, because you have a lot more inpatient use. And then obviously, Melanie, we want your feedback. But just getting the buy-in from your staff, how did you do that? And how did you overcome some of the challenges?
Great question. So one of the tools that we've used to really get buy-in from the bedside staff, especially in the pediatric population, you nailed it, Dana. Pediatric nurses are so protective of the children that they take care of. And as a mother of 3, I'm so grateful for that. But we do a lot of, I have done a lot of rounding within the Wolfson Children's Hospital and throughout the pediatric population. I'm a big face-to-face person, which is hard in this electronic age, but I like to go meet with managers and A&Ms and staff and bring a camera with me, show them the camera. Once they get hands on it, I feel like they're a lot more comfortable with it. We ask our A&Ms and nurses from the pediatric population. I have set up some rounding dates through our video monitoring unit. That's what we call our department, the VMU. And they round through here periodically on a routine basis in order to meet the techs and see them. We also have an idea that we're putting into fruition now, and that is on our devices. We want to have a stack of laminated cards that show the tech's picture and their first name and like a fun fact about them, especially for children, something that the children can relate to. And that way they're able to really put a face to the voice that's behind the camera for them. But for us, it's been a lot of work behind the scenes to build trust and to send out the good catches. We try to send out the good catches weekly and monthly to get buy-in from the staff that this is a great tool for them to use. And really, our health system has embraced this well because we have been able to put ACPs back on the floor through the use of Avishere. So we were pulling a lot of our ACPs to be in-person one-to-one sitters. And so the staff has embraced this because they've been able to get ACPs back to the floor doing ACP work instead of using them as a one-to-one sitter. Those are some of the ways that we have built trust. And Dr. Gunn might have something in addition to that, since she was instrumental in getting Avishere off the ground for our health system. And she has been there since the very beginning, August of 2020. So she might have an additional way that she's gotten staff buy-in.
Yeah, so just so everybody's aware, we did invite Dr. Elizabeth Gunn, who is the VP of Inpatient Services at Baptist Health. So she's done some remarkable work there, and she can share some information and insights. And then towards the end too, we can talk through the ROI, because we know that's a compelling issue that we have to talk through as to how are you going to get funding for this and how are you going to validate funding. So Dr. Gunn, if you want to piggyback on what Catherine has said, that would be fantastic.
I can always count on Catherine to do an excellent job outlining everything that we've done together. I will say that in the very beginning, one of the things that we did do is we presented the evidence out in the what was in existence when we began our pilot here. And it doesn't hurt that we actually started our programming when we were desperately short of staff across the board because of huge increases in census during the COVID crisis. So our staff was very eager to embrace anything that would help them have eyes on their patients, because they were feeling the burden of not being able to be everywhere at once that they needed to be. And the time that it took to get in and out of isolation, they felt like they wanted early warning of any patient that was maybe about to come to harm, because they needed a moment to properly gear up to go into the room to care for the patient. And so those were advantages that made adoption a little easier than it might be if you take off today. But the other thing is, Catherine hit it right on. We started with adults and actually moved into pediatrics over the course of time. But one of the things that we did, we were very, very careful in selecting the individuals who were going to be the virtual safety monitors, technicians. We chose our most seasoned and successful CNAs to be our first group of monitor technicians, because we wanted people that had the skills to recognize what they were seeing and the verbal de-escalation skills. And because we chose such highly valued members of the team for that role, the other team that was going to be on the floor entrusting part of their patient care and oversight felt like they were entrusting them to valued members of the team that they already knew. So when you're going to do it, and we have had to grow that, and there are a lot more people there, hence the work that Catherine just mentioned with the rounds and the team meetings, to make sure that your video technicians, your safety monitor technicians, are still considered a part of the care team on the unit. That's what I think drives our success.
Perfect. That was great. So Melanie, over to you. I think Melanie might have froze a little bit. While we're waiting for Melanie to come back, we will go ahead and do another poll, and it is all circled around what kind of challenges you might foresee that your organization would have rolling out a virtual telesitter platform. So if we can go ahead and run that, and then we're going to have Melanie talk about her program and about how she got the staff to buy in on that as well. You're up, Melanie. You can answer while they're doing the poll.
Oh, great. Okay. Yes. So a lot of, echoing off of what my peers had said on the call, but the biggest thing for us was really to get the staff to buy in, was including them from day one. So as soon as we knew that we were possibly going to be a pilot unit or hospital, talking it up at huddles, asking staff their thoughts, bringing it up at staff meetings, I actually got to go to a community hospital that was, relatively close to us, that had already been utilizing AvaSure. And I took members of the team with me, from, a tech to a nurse to my clinical supervisor, because I wanted all of their feedback and their experience, that they could see what a benefit this is. Prior to AvaSure, we would have to pull our techs to sit on patients, regardless of their acuity scoring. And that really pulled resources from the floor, and helping the nurse, in addition to, getting the patient in and out the door faster. So really the biggest buy-in for my staff in the ED was that they would, not have to be pulled from their job and essentially work shorthanded to support, sitting when a patient didn't meet the criteria to do so. I think, overall too, for us, we have about $250,000 in savings every year from what we used to pay a sitter to, utilizing the AvaSure. And that's a lot of money. So, I always ask my staff, what do you need to do your job better? So when they say, like, we could use 2 new EKG machines, so we can, kind of help them relate that, this is cost saving and helping us get resources that we need.
Perfect. Well, I am so excited. We have so many questions in the chat. Let me start with, we have a question from Karen Carroll. I will answer it from Avishure's point of view, and then I would love for your point of view as well. Is there a consent needed for this type of monitoring? To clarify for everybody on the call, Avisure does not record any video or audio. So per the Joint Commission requirements, you're not required to obtain a consent. The couple guidelines that you have to meet is, you obviously have to let the patient and the family be made aware that you are monitoring them. You have to put the monitoring team in a safe, secure location so that passerbys can't see into the rooms, because that's a privacy concern. And then it has to be medically necessary. So from Avisure and Joint Commission's perspective, you do not require a consent because there's no audio or video recording. But I don't know, Melanie or Catherine, do you have anything to add, or are you requiring a consent?
We do not require consent. We do really push the communication because I think it's really important to educate the family and the patient that it is not a live recording. When I get hesitation, which is not much, that's usually the concern. And so once they realize it's not a live recording, I think they feel a lot better. And then, we've kind of done something similar to Catherine, is we initiated kind of the face behind the monitor, where if they wanted to, they have a picture of themselves that we hang on the Avisure monitor, so they have a little bit of a connection with who's watching them. But that's basically just really communication. It's in our welcome packets. There's a handout about Avisure explaining it. But really, knock on wood, I've had very few concerns about that.
And Catherine, how about from you?
Yes, I would echo what you both have said. We do not require consent. It's part of the patient's just general medical consent. Again, not a recording device, is not part of the patient's medical record, so we do not require consent. Occasionally, very, very occasionally, we will have a parent that has questions. And again, like Melanie said, we just educate them. And for the most part, almost every single time, they're grateful for Avisure, and there's no issues with it. Once we explain that it does not record, and that there are Baptist staff members on the other end that are trained by our health system and are credentialed, they are completely comfortable with it. So no issues with that for us.
Perfect. And I think one other thing to point out on one of our initial slides, since both of your organizations went live with Avisure, we have updated our devices. So now we do have the capability to do two-way video and two-way audio on those mobile devices. And my big vision for pediatric environments is it'd be so much fun if you had your virtual monitor tech dressed up like as a princess or as a superhero, and tell them that they have their own personal, fairy godmother watching over them to help them with the buy-in, and that way they can see it. So that is a possibility, as well as folks on the call are starting to think about this journey, that we do have the capability to have that two-way video and audio component. I love all these questions. We have some more. So a couple of them is about with your criteria for your suicide ideation. What tools are you using to identify those patients or to score them? And then just kind of talk a little bit about your inclusion process, especially for that patient population. So Melanie, I'll start with you on this one.
Yep. So we screen anybody age 13 and up that comes into the pediatric emergency department for any complaint, and then any age if they arrive with a mental health or behavioral health concern or complaint. We use the ASQ, which is the Ask Suicide Questionnaire. It's a 5-question scale, and the 5th question determines their level of acuity. So based on how they answer the 5th question, deems them more high risk, requiring that they need that sitter within arm's reach, or they fall into the low to moderate category and can be a candidate for the Avisure monitoring system. Okay. Obviously, nurse intuition can always trump that, or if you feel like the patient's not being truthful, we always err on the side of caution.
Perfect. And you only use it for the low to moderate patients?
Correct. Okay. The high risk patients have to have that one-on-one sitter within arm's reach.
Okay. And Catherine, what about for you? What tools do you use and your criteria?
So we use our mental health evaluators and psychiatrists use the Columbia scale. Avisure is not deemed appropriate for a patient that has not been assessed by a mental health evaluator or psychiatrist. Once they have received this assessment and they are determined low to moderate risk for suicide or homicide, it is appropriate and within our protocol to use Avisure. Like Melanie said, high risk for suicide or homicidal ideations requires an in-person one-to-one sitter for our health system.
So, and there, it kind of is leaning into this, Deanna Bennett is asking, they use Avisure, and how did you get physician buy-in to allow you to use Avisure for those low to moderate? I think that sometimes is a barrier, is for allowing the physicians to allow this type of technology to monitor those patients. Did you have any challenges when you did roll it out for this patient population, this pediatric population, from the physicians, or did you have to go through any types of committees or any kind of groups that you had to make sure that this was appropriate for that patient population? Catherine, you can go, you're off mute, so you can
Okay.
go first.
Dr. Gunn, I'm going to defer to you on that. In my experience, we have not had any concerns with that, but Dr. Gunn might have had some from the beginning.
The pediatric psychiatrist had a bit more concern about entrusting the observation of children to the video monitor technician. They tended to continue to ask for the one-to-ones that are, you know, in the room with the patients. We have shared with them outcomes data and real world cost data, because, you know, that's confining how many other people are available to do what throughout the rest of their care environment. And they're making gradual improvements. They've discovered that we can be just as effective, for example, in monitoring children with eating disorders via virtual, by giving the staff the heads up that the patient has made an unscheduled or undocumented trip to the restroom. They've headed into the restroom and those kinds of things. And so we're gradually getting better buy-in from it. We did include members, physician champions at the top end of our protocol writing. We knew what the law was. We knew where we were trying to get to based on the evidence that was somewhat limited, but the evidence that was out there in the world. And we included, and we were fortunate enough to have, you know, a pediatric psychiatrist and a general adult psychiatrist, as well as various members of the medical staff leadership team and our administrative leadership team that worked together to come up with. And we really allowed our behavioral health team to help drive the protocols so that they would feel comfortable with them.
Perfect. And what about for you, Melanie? Did you have any barriers with this patient population?
No, thankfully not. My medical director is incredible, and she actually came with me to the other, you know, institution to kind of learn about Avisure. And then we just, you know, made sure our communication was there, going to provider meetings, going to the local pediatrician meetings. You know, the local pediatricians meet once a month at our hospital, and so just educating them. And that they, you know, they helped with some of the decision making with what age we were screening, so that we can ensure consistency amongst providers in the community. But no, really, you know, no barriers, thankfully.
That's great. So getting into the workflow, because that is a question from Jennifer Carpenter in our chat, and a couple of other folks want to know. So can you talk through the workflow from the devices in the room with the patient, and talk about your redirection, how you redirect them, but then also how you communicate with the bedside caregivers to make sure that they are aware without using maybe the stat alarm. And for those folks that are maybe new and unfamiliar with Avisure, you can communicate and redirect directly through Avisure to the patient. And we do have the capability to trigger a stat alarm. And I think the question is around, how does your virtual monitor staff communicate with the bedside staff if they need to get in the room quickly? So I'll start with you, Melanie.
Yep. So we give report on every patient at change of shift. So the bedside nurse is giving handoff to, we call them our senior patient safety attendants on the patient. So that handoff is crucial because it includes the phone number where if they need to call the nurse, they have the direct line to the nurse. And it also is helpful because it lets them know, like, you know, this patient, you know, doesn't have the best relationship with their grandmother. So if you could let me know if the grandmother comes into the room. So it just gives a whole understanding of the patient and potential triggers. If you know them, you can share with the senior PSA. So, you know, the charge nurse phone number is always the same. So they know those, and they have kind of a quick list in their office of my phone, the charge nurse, the medical director, if they can't get the bedside nurse in addition to the techs. But it's definitely crucial to give that handoff at change of shift.
So to clarify, all of your nurses are carrying some type of device, and
Yes.
they carry a phone. And so when they do that handoff, they are giving that phone number to that nurse for that shift.
Yes, and they're giving a report on that patient. Yeah, and generally we cluster our assignments. So like the nurse is going to have probably the 4 that are on the cameras, and they're going to give handoff on all 4 of those patients.
And they do that every shift?
Yes.
Oh, fantastic. Okay, great.
Yep. Even for a lunch break, they have to give handoff.
Okay, perfect. And then how about you, Catherine? How does your monitor staff communicating with the bedside nurses?
So we use Vocera. I saw that Jennifer Carpenter mentioned Vocera. Vocera is our communication device from what we call the hub. That's where we're located. We're about a mile from the nearest hospital. We use Vocera to call the staff at the bedside and alert them that the patient has a need or some sort of safety issue, whatever the reason is we're calling. Each of our monitoring stations has a laptop, and we can use Vocera staff assignment to call through the laptop. It then goes on to the badge device that each of our monitor techs wears. And also each bedside staff member in the hospital wears a Vocera for the shift. So ACPs, nurses, A&Ms, managers, the house supervisors, we can all reach them via Vocera. So if the announcement is not able to redirect the patient through the device, through Avisure, or a verbal intervention is not successful in redirecting the patient, we try not to use the stat alarm for the pediatric population. But then we will use Vocera to call them and connect with them immediately to let them know of the patient concern. And then we also, similar to what Melanie said, we are touching base with the nurse that is the primary nurse for the patient every shift to make sure that we are watching for the appropriate things for each of the pediatric patients.
You answered my question. I was just going to ask you, because some of the feedback sometimes I get when I'm out in the field is that stat alarm is so loud and so jarring in a pediatric population. Do you use it often? And are you always using it? Is your first line of defense, if you can't redirect, to go to the nurse?
Yes, we try not to use the stat alarm for the children unless we absolutely have to prevent self-harm or harm to another person. That is for the pediatric population, that is our last effort in order to redirect the patient. The only time we use the stat alarm more than we would use an announcement or a verbal intervention or a call via Vocera is for an elopement risk. So if we're watching a child in an ED or any of our inpatient settings and they are getting ready to elope and we need to get help immediately, we will use the stat alarm in that circumstance, because it takes a minute. It's brief, but it does take a few seconds to connect via Vocera because we are off site. So we have to connect to the facility and then make the call. That can take 10 to 15 seconds. So we will use the stat alarm if needed for self-harm, harm to another, or for an elopement. If we're truly worried about the child, we will use the stat alarm, but we try not to because it is loud for the children.
Yeah. And how about for you, Melanie? Are you the same?
Same. Yeah, we really try not to, hit the stat alarm. The monitor, technician will speak to the patient to try to attempt to bring them back, if they're getting close to their door. But we do use it if they would, that elopement risk, or if they go into the bathroom and shut the door. Like there's no locks on our bathroom doors, but there's no visibility if the door is shut. So anytime they go to the bathroom, they need to be, watched by a staff member, but we generally try not to press the alarm if possible.
Okay. So we do have another question. Talk about your shifts. Are your monitor techs, are they doing the same shifts? Are they doing 12-hour shifts? Can you talk a little bit about your program from that perspective, from staffing? Catherine, you can go ahead and go first. You're on mute.
Thank you. We do work 12-hour shifts, same as the hospital bedside staff. So we work 2 12-hour shifts, 6:45 a.m. to 7:15 p.m. or 6:45 p.m. to 7:15 a.m. So we are all pretty much on the same schedule for the nurses and the ACPs, the A&Ms, and the bedside staff.
So do you have any challenges with the visualization of those patients during shift change?
No, we have a process where the tech that is the safety monitor tech that is going off shift gives a report to the oncoming safety monitor tech. They give it room by room on each of the patients, and they are not allowed to log off until the report is given. And then there's a quick shift change, less than a minute, and then the new tech logs on. And we also, one of the unique parts of our program that Dr. Gunn was instrumental in ensuring, and this has really given us even better success with the program, is that we have a lead every shift, and the lead is like an upcharge nurse. He or she does not have an assignment. So one by one, the techs log off and the lead has their patients pulled up. So we do not have any downtime, even for a second, where we have eyes off a patient. the lead takes over each person's assignment as they log off, and then the next person logs on.
Perfect. And how about you, Melanie? What does your shifts look like?
So our telemonitoring shifts are the 12 hours, 7P to 7A, 7A to 7P. The ED shifts are a little different because we staff to volume. So there could be times throughout the day where the nurse is handing off. But again, the new nurse that comes on introduces themselves, verifies the phone number is correct, gives any updates that they might have. And our nurses do bedside shift report. So they're in presence of the patient when they're doing report.
Okay. I will explain this one to April. She wanted to get a little bit more information about the stat alarm. So the way that the stat alarm works within Avishere, your virtual monitor tech can go ahead and trigger that alarm locally from there where they're monitoring the patients. And the alarm comes through the actual device. It doesn't matter if it's a ceiling device, a mobile device, or our new wall-mounted device. It's a very loud, audible tone, and that's why Catherine and Melanie say that they don't use it as much in the patient population of the pediatric environment. But we can also integrate it with your nurse call solution. So if you want to have that stat alarm triggered, obviously it will alarm locally, and then it can alarm at your nurse call to go overhead in your unit, and then it can illuminate your dome and zone light, and then notify the central station of where that's going off. It's very loud. It definitely brings folks to the room. Our average response time nationwide is about 16 to 18 seconds. And the reason why our stat alarm response time is so powerful and quick, it's because it's a human validated alarm. It's not artifact. It's not like we get in our old days with bed exit alarms where they would go off arbitrarily. It's actually validated by a human being, and they're waiting for that caregiver to get to the bedside before they cancel it. So it's a true indication of the response time from that stat alarm being triggered. I'm telling you, this is so great. We only have 3 minutes left. I think we can talk for another hour because it's so compelling and everybody really wants to learn more about the pediatric environment. I want another one before we close because we only do have a couple minutes, and it's kind of geared towards you, Dr. Gunn. Have you seen a decrease in staff injuries with Avishere or other outcomes to justify your cost? So I was thinking more about the cost and then obviously injuries.
The injury component of it, I can't necessarily say that we've seen fewer staff injuries, but I can say that we have seen an improvement in response to patient violence against staff, right? We've literally had our Avishere safety video technicians call for help in a room when the team member had been isolated from the door and couldn't call for help for themselves. And so that has been that's been a positive. People have appreciated having that. And as a matter of fact, when we have had to have an in-person sitter because of the patient's recalcitrance and inability to manage them for even a few minutes at a time without someone right there at their bedside, we still put Avishere in there, and that's why it's there. It's there in case that patient turns on the sitter so that they're not isolated alone in that room. So we sometimes spend two sitters on a particular patient. So that was, did you have something else that you wanted to know from me?
You were just talking about justification, especially from a cost perspective as well. So just wanting to go ahead.
In order to get, just very, very briefly, because I know we don't have much time left, very briefly, we were able, and you're perfectly willing to share my contact information if people have more detail they'd like to know about this. But very briefly, what we did was we took a very conservative approach. We assumed that if we purchased X number of devices and utilized them 75% of the time, it would be this many patients. We looked at what we were able to field in terms of one-to-one sitters, not how many could we have if we had had enough people to go around, but how much money were we actually spending on it. And that was a little dicey because we had people being pulled off their normal duties to provide one-to-one care, and we weren't really always able to capture that. So looking at this very, very conservatively over a 3-year time frame, we were able to appreciate a $250,000 return on investment in the first year. And that just grew because we're an organization that likes to own our property rather than lease it. And therefore, once that capital investment in the in the monitors themselves was paid for, we saw an improved, so the advantages were we did actually decrease falls of the patient population, the adult patient population. We increased by probably 5-fold the number of patients we were able to monitor and provide that safety to. And we decreased our overall cost for in-person sitters by about 50%.
Perfect. Well, I know we're coming up to time, but I don't think it would be fair if we don't share at least a good catch, because I think you're doing amazing work and I think that helps validate your programs. So Melanie, why don't you go ahead and share a great catch that you guys have experienced at your organization?
Sure. One was actually during COVID. So, everyone was wearing a mask. And the telesitter had called the nurse and said, it seems like room 8 is really fiddling with something in their sock. And she's like, I can't figure out what it is, but they seem to really be like messing around with something. She's like, I've zoomed in, I can't see anything, but it's definitely, I suspect that there's something in the sock. So when the nurse went in there and assessed, unfortunately, the visitor had a mask that had a wire kind of nose bend. And the patient had pulled that out of their mask and put it in their sock. So whether their intention was to harm themselves or somebody else, it was a great catch because the nurse went in there and was able to retrieve this like wire metal piece from the patient.
Perfect.
So.
And how about you, Catherine? You want to leave us on a positive note as well?
Sure. We've had so many great catches. It's been amazingly successful here. But we had one a few months ago of a patient that actually a pediatric patient, a male patient that was 17 years old that was in for self-harm. And we were able to, the safety monitor tech was able to notice that he had been laying in bed all day and was very inactive, sleeping on and off, things like that. And then he got very, very active and had a plan, I think, to remove the sheets from his bed and to hang himself. And the safety monitor tech, before he even got to the point where that was even a possibility, noticed that he was making his bed repeatedly, unmaking his bed repeatedly, up around the room a lot, checking at the door to see where staff was right outside of his room and things like that. And she was able to call the nurse immediately and say, the patient's been asleep all day, laying in bed. It's 3 o'clock. He's suddenly very active, very fidgety, very agitated, walking around his room, messing with his sheets repeatedly. And they were able to talk to the patient, and he actually was having a voice that was telling him to harm himself. So the nurses and physicians were able to intervene immediately for him and to get him the help he needed. And so that tech potentially caught and prevented a potential self-harm event.
Well, thank you so much. Well, I think we could probably spend, like I said, another hour on this. It seems like everybody's really interested. On that note, we do have one last poll, and it is more geared towards furthering this conversation. So what Avishere is looking to do at the end of July or August is to have a roundtable of pediatric care providers come together and have a discussion about using this kind of application within your organization. So if you would be interested in joining our roundtable, we would love to have you. We would be reaching out to you and contacting you. I feel as though we're going to probably need a part 2, because I don't think we've gotten to all the questions. I think you guys have just touched the tip of the iceberg about your patient demographics and how you're using Avishere. And I'm sure if we come back together again, you'll have even some more amazing, great catches to share. So it looks like quite a few people want to join us for a roundtable. Melanie and Catherine and Dr. Gunn, I thank you so much for joining us. I hope this was worthwhile for everybody on the call, and I appreciate your guidance and all the amazing things you're doing to keep our pediatric patients safe. So thank you all, and have a wonderful rest of your day.
Thank you.
Thank you.